We're going to see now the anal diseases. So we will see hemorrhoids, fissure, fistula, abscess, and the cancer. So here we have the pectin line or dentate line. This is the anal canal above pectin line, below pectin line. Here the innervation is visceral innervation. This is somatic innervation by the pudendal nerve. So the only innervation that will be felt is the one that is below the dentate line. Now, the blood supply, here we have the superior rectal artery, that is branch of the inferior mesenteric artery. Here we have the superior rectal vein that drains to the inferior mesenteric vein, and then splenic vein, and then portal vein, suprahepatic veins, inferior vena cava. Then the lymphatics, here we have the drainage to the internal iliac lymphatics or lymph nodes. And below the pectin line, we have the middle and inferior rectal arteries that drain to the, or that are branches of the pudendal artery, that in turn is branch of the internal iliac artery. The venous drainage is the middle rectal and inferior rectal veins that drain to the inferior mesenteric vein, and to the pudendal vein, and then to the internal iliac vein, then common iliac vein, and then inferior vena cava. And the drainage is to the superficial inguinal nodes, the lymphatic drainage. Now, the things that occur above the anal, the pectin line, are the internal hemorrhoids. Let me put it in another color. Internal hemorrhoids and the adenocarcinoma. And what is below are the external hemorrhoids and squamous cell carcinoma and the anal fissure. So first, the hemorrhoids would be these tortuous blood vessels, dilated blood vessels that can bleed, and they would present as hematochezia. The treatment would be with try to give more fiber, seeds, baths, etc. If this doesn't control it, then for the internal hemorrhoids, we do surgical, band ligation, and then if this doesn't work, surgical removal. Also for the externals, the surgical removal. The difference is that because here we have visceral innervation, the internal does not feel black pain, and there is pain sensation because this is somatic innervation, this is visceral innervation. Now, the anal fissure, we will present with pain at rest that is exacerbated by defecation. The fissure could be, let's say, acute or chronic. Acute is less than 8 weeks. Chronic is more than 8 weeks. This usually occurs on the posterior wall of the midline at the anal verge because the posterior wall is less perfused. The diagnosis is made clinically, but sometimes we can aid on the diagnosis if we make the patient to feel the pain at the distension of the anterior or posterior midline of the anal verge. So this will be a sign or something that will skew us to the diagnosis. Here the treatment will include fiber because the risk factors include constipation, severe diarrhea, heart evacuations. So fiber, stool softeners, and we want to dilate, so we can give nitroglycerin or calcium channel blockers. If after 8 weeks this doesn't work, then we do internal lateral sphincterectomy. And in a way similar, the fistula formation, this occurs secondary to a abscess of more than 6 weeks. Now the abscess, the ischiorectal abscess presents as a fluctuating mass, hot, red, with or without fever. The patient is in severe pain. The treatment is surgical drainage under anesthesia. The most common location is just lateral to the anus and between the ischial tuberosity and the rectum. Now, if we have persistence of this abscess, then this can lead to the fistula formation. The fistula formation would present also pain, more with defecation. And the cancer, fistula can lead to cancer, and this would be squamous cell carcinoma. So yes, here the fistula is below the dentate line, as well as the squamous cell carcinoma. This would present as a fluctuating mass. And I forgot the rectal prolapse. Rectal prolapse could be full thickness or partial thickness. Full thickness would be managed with surgery, and partial thickness most of the times medical treatment like stitch baths, etc. Other indications for surgery would include if the patient has a lot of debilitating symptoms like diarrhea or constipation. The risk factors include advanced age, multiparous woman, constipation, diarrhea, pelvic dysfunction or anatomic defects of the pelvic muscles, etc. And the treatment would depend on the symptoms and if it is full or partial. So these are the analyses. Now in the next video we will continue with that of the gallbladder section.